So, patients that are admitted for acute inpatient treatment, really we have to look at that suicidal ideation immediately because many times these patients are admitted in a crisis situation. Their weight is at an all time low. Physically, they may even have had some episodes of fainting or some other physical difficulties. And now they are in a facility, and part of them probably realizes that they are going to be forced basically to gain weight, and that's very distressing for them. So they may be acutely suicidal, especially on admission, because it is just so absolutely frightening and distressing to them. So we really need to monitor that very, very quickly. And then the interventions, of course, that would follow might be possibly as stringent as putting somebody on a one-to-one. Certainly every 15-minute checks would be the minimal type of intervention, and of course keeping the milieu safe. So really have to concentrate on that, looking for suicidal ideation, intervening appropriately, and of course establishing a rapport with the patient is going to be very, very important. So psychosocial interventions, well, really there's lots of psychosocial interventions. Basically, you are going to be um, working with that patient to bolster their self esteem because, again, their self esteem is tied to the number on the scale. So it really is helpful to help that person to look at their overall self and actually be able to identify strengths and weaknesses, especially strengths and positives that are not related to their body shape or size. So as patients are slowly but steadily gaining weight, again, about a 1 to 2 pounds, not usually much more than that per week. So as they're gaining that weight, we really need to help them focus on their feelings of anxiety, low self-esteem, and then of course, going along with that is lack of control, because that really kind of leads us back to what was part of their um, reason for, I guess, for having exhibiting some of those anorexic behaviors, anyways, was to exhibit control, absolute control and mastery over their body and their hunger. And so now they're feeling out of control as they are eating. So it really helps to have a lot of interventions that are based in the milieu. Most of the time, a patient is most successfully treated if they're actually on an inpatient eating disorders unit, a unit that's actually certified for that. So, for example, 1K is not certified as an eating disorders treatment program. Therefore, we really don't treat. If a patient comes to us, we see that they have a history of eating disorder, but that's not the primary reason why they're there. It's hard to ignore, but on the other hand, we're not going to be actively treating it the way they do on an eating disorders unit. So that's not to say that we can't help them with that if they start to struggle with the eating disorder. But if truly the eating disorder became the primary focus, more than likely they would be transferred somewhere else. So larger cities around us have specific eating disorder units, because you really have to create kind of a different type of a milieu that is more structured than and really focuses on eating and the anxiety that that creates for patients. So it's kind of hard to do that in the general milieu when other patients really can't relate to that issue. It's interesting that at the very bottom of page 338, the very last line says, approach discussions about physical appearance carefully because the patient could misinterpret comments. I would guess that probably the best thing to do would be to avoid comments on their appearance at all, because again, I think I told you in my last recording that I've had students actually tell me that they have struggled with eating disorder issues and they consider themselves recovered. However, if somebody tells them, hey, you look really good, their immediate interpretation still is that, oh, I've gained weight. I must be looking really heavy. So we do have to watch. It's probably better to comment them on other aspects of their personality. and maybe their participation in group, or maybe if they're working on a project in art therapy or something like that, it'd be better to compliment them on some other aspect of themselves rather than their physical appearance. So group therapy certainly would be also part of that psychosocial intervention, not just the nurse maintaining a therapeutic relationship, but also group therapy. And the timing of group therapy is kind of important because um, many times right after a meal is a very difficult time for that patient because they're just feeling so out of control, and eating just brings up so many bad emotions, difficult emotions for them. So sometimes it's really helpful to be able to talk and think about what they're feeling. Also, the other flip side of that coin is that if you engage people in something productive after a meal, then that also could possibly take the place of one-to-oneing them after a meal, because that is another intervention that's used to make sure that that patient doesn't use the bathroom and induce vomiting after a meal. Because some people with anorexia, that's more typical of bulimia, but some people with anorexia do purge after a meal, especially if they're feeling extremely anxious and worried about gaining weight. Pharmacological interventions. There's no specific medication to treat eating disorders. However, medications like Prozac have been shown to be useful in reducing a little bit of that obsessive compulsive nature after the patient has reached their maintenance weight. Again, if they're at an extremely low weight, if they're very, very low, it may be difficult to put them on an antidepressant because of potential side effects. So you put them on something that's going to cause orthostatic hypotension, and already their blood pressure is 70 over 50. That's not going to go very well. So usually medications are most helpful when they've at least reached about 90% or so of their ideal body weight. Integrative medicine kind of talks about some complementary approaches that might be used. Biofeedback, acupuncture, yoga, massage, possibly herbals. We should always assess if people are taking herbals, because sometimes people do try to use those and self-medicate. So they might be using St. John's wort for depression, valerian for sleep, or chamomile for anxiety. So we kind of need to keep an eye on that too, because some of the herbals actually have side effects that might be contraindicated with their illness or actually make things worse. So we do need to take a look at that. But certainly different types of therapies and yoga, different practices like that that can help people to become more calm and centered could possibly be very beneficial. Health teaching and health promotion, that's really kind of a big area for people with eating disorders, because they almost need to be retaught what a healthy meal is. They truly don't have any idea what they should be eating and portion sizes and just what a normal breakfast, lunch, dinner, or snacks would look like. So that's actually a huge part of their health teaching and health promotion. We should always be promoting them just having good, healthy lifestyle habits. Exercise is something that is used excessively much of the time, and so even just a basic primer of education on what's normal amount of exercise in a day, how much really should they be doing. And actually, they have to usually put a cap on the amount of exercise that they do, especially until their weight is a little bit more stable, because sometimes people will try to exercise even in their bed, when they're supposed to be sleeping. Nurses have caught patients under the covers exercising. So, because they're really so worried about gaining weight, they're trying to burn off as many calories as they can. So, just to have a good basic knowledge of how much exercise per day, what is considered healthy, and then what is considered excessive, because they truly have lost sight of that. Coping skills and more adaptive ways to cope are also certainly part of that health teaching and health promotion. So safety and teamwork, the milieu, everybody certainly needs to know about what's going on with all of the patients, so that in case anyone happens to be in the hallway or walks past a patient's room, that they might be in tune with different aspects that they may need to address. So again, that's why we listen to, not that we have eating disorder patients, we don't treat them for their eating disorders on 1K, but we certainly listen to report on every single patient so that we can all be very effective in that milieu. Monitoring of the patient is absolutely one of the top priority interventions that you will do with somebody that has an eating disorder. It may sound extremely rigid, and it really kind of is, but they have very, very strict protocols for everything. So they have very strict meal times, the food selection, that weighing, observation, of course, during and after meals, and scheduled weighing. Now, weighing, I would guess, would probably be once or twice a week. I don't think it would be more than that. I would guess the person that suffers, especially from anorexia, more than likely had been weighing themselves at home obsessively, maybe several times a day even. So that would absolutely not be a good intervention. And actually, one thing that I have seen, I think in your book it talks about that it may or may not be part of the treatment contract for that patient actually even to see their weight or be told their weight. Actually, the unit that I was familiar with back in New York, the patients were not allowed to see their weight. They were weighed backwards, so they could not see the number on the scale. And they weren't told. I don't know at what point, if they were ever told their weight. Yeah, I know this was back, 20-some years ago, but 30-some years ago, I guess. But still, they were not, as far as I knew, they were not told their weight because they did not want to have that patient associate their self-esteem and their self-worth with that number on the scale. So the other thing about weighing, that the patient needs to be monitored very carefully before they get weighed. Many times patients would try to get into the bathroom and drink copious amounts of water in order to look like they've gained weight, so that it looks like they're adhering to their treatment program, when actually it's going to be a false high, because drinking a whole bunch of water right before you weigh yourself, you're going to weigh a little bit more. So to prevent people from doing that, or sometimes people would put pennies in their underwear to make them, again, look like they're gaining weight appropriately when actually they're not gaining weight. So, so that little bit of manipulation that can kind of occur, we really have to make sure that we intervene and set limits so that patients are gaining weight appropriately, and they're not just looking like they're gaining weight by doing various things to, to make the scale look like it's a little bit higher. On page 339, there's a little bit of a vignette, talks about a 20-year-old woman, and just a little bit of a vignette about how the importance of bathroom monitoring, and even just thinking about monitoring visitors too, because sometimes visitors may come and it might be almost like an enabling type of thing, and they're trying to keep that person sick, and they may actually bring them laxatives or diuretics. So, we have to kind of monitor that too. But that vignette is very interesting because it really does talk about basically invading the person's privacy, which is what you're doing when you're having so much close supervision in the bathroom. But people do abuse bathroom privileges, and they will self-induce vomiting. So that is something that they really have to be the nurses have to be very alert for. And when patients are on a unit like this, they do sign a treatment contract so that they know what's to be expected, and they know how much structure that there is in the loss of privacy. Those can become very important patients' rights issues. I can't talk. Advanced practice interventions can include, of course, individual, group, or family therapy, all of which are really important to help that person on the path to wellness. And families really need some information, and they also need to know how they should be interacting with their ill family member in a more helpful way. So, the families really can feel very powerless. Sometimes families even try to force people to eat, and they really try desperate measures because they can see that person withering away right before their very eyes. So it really is helpful to help the family to learn to communicate better, and so that they can really truly support that person on their road to recovery. Starting on page 340 in Varkarola's, there's a really nice case study and nursing care plan. So they really go through the interventions, the rationale, and kind of what a breakdown of what might happen during a several-week hospitalization. So I definitely would encourage you to read through that. And one thing they do mention is an intervention is sometimes liquid supplements are ordered, especially if the patient is refusing to have to eat solid food. They may be given a meal replacement shake or something like that. So very important to make sure that that person eats. Whether or not a patient gets tube fed if they are not eating or drinking fluids appropriately, I would guess, I'm not really sure. I guess I didn't really see much of that happening. But if somebody was in absolute serious medical condition to the point where it would save their life, then I would guess there would be some legal proceedings that would have to take place, that the patient would be fed against their will. If the patient certainly was happy to have tube feeding, then that would be another issue. But if that person really insisted that they did not want to gain weight, did not want to eat or drink anything, and they were just going to starve themselves, then the court system may have to take place. They may have to make some decisions. So, anyways, really good case study and nursing care plan. All right, now another little case study that they put in the PowerPoints. Addie, age 15, is brought to the school nurse after fainting during gym class. She is grossly underweight, wears baggy clothes, and has dry skin. She complains of feeling cold despite wearing 2 sweaters. As the nurse examines her, she notices that Addie's skin seems slightly yellow, and a gentle scrape of her skin shows signs of dehydration. So Addie recently fainted during gym class. She's grossly underweight, baggy clothes, skin is dry. To further assess for anorexia nervosa, the school nurse should ask, A, do you often wear heavy clothing in warm weather? B, when was your last menstrual period? C, do you use any drugs or alcohol? Or D, do you ever have lapses of time? So I'm hoping that you pick B as the most appropriate to ask about her, just looking at kind of her overall health. And certainly if somebody has fainted and they're wearing baggy clothes and they look like they're very underweight, any type of question like that that would look for further symptoms of anorexia would be very appropriate. Continuation of the case study. Earlier, we learned Addie's skin was slightly yellow and her skin showed signs of dehydration. What is yellow skin and anorexia nervosa linked to? Lanugo, amenorrhea, use of street drugs, or hyperkeratinemia? So I'm hoping that you picked D, hyperkeratinemia. So apparently there is a abnormality that happens in the metabolism of keratin, and so sometimes the patients actually have like a yellowing, usually seen in the palms of their hands and the soles of their feet. But it's not the same thing it's not the same issue that happens when people have like liver failure and they have yellowing of their skin and their eyes. In this hyperkeratinemia, the eyes don't become yellow. So it's not a liver issue. It's an issue of the metabolism of keratin. Addie's condition worsens and she collapses at home. She is admitted to your unit with anorexia. You have completed your physical and biopsychosocial assessment of her. Which common personality trait is likely to present a particular challenge? Lack of hygiene and cleanliness, lack of interest in self and others, irresistible desire to purge, or perfectionism. So once again, I'm hoping that you picked D, perfectionism, that is a personality trait that can be extremely difficult to work with and can be very frustrating for nurses. So we as nurses really need to, again, always kind of watch our own feelings and attitudes, make sure we don't have any countertransference reactions, and treat the patient with dignity and respect, and also to make sure that we don't get pulled in sometimes to that manipulation, and just really not take things personally. Another audience response question: hypoalbuminemia in a patient with an eating disorder would produce which assessment finding? Lanugo, jaundice, amenorrhea, or peripheral edema? So you're probably thinking, oh my goodness, this is sounding like CHA 1. Sounds like a med-surg course, but no, it is peripheral edema. But we really do have to make sure that we pay attention to the fact that the physical findings in eating disorders, especially anorexia, certainly can be life-threatening. So we really do have to be aware of the physical as well as the psychological aspects of the illness. Okay, now we're on bulimia. So the assessment is that person with bulimia might appear well. Most of the time, they're going to appear well. They're either at or near their ideal body weight, usually like maybe 10% above or 10% below their ideal body weight. So that is really considered really quite a normal weight. They may have physical signs like enlarged parotid glands, dental erosion, Russell's sign, and dental caries if the patient has been inducing vomiting. Bulimia itself is characterized by repeated episodes of binge eating followed by that inappropriate compensatory behavior, such as vomiting, misuse of laxatives, diuretics, or other medications, possibly fasting or excessive exercise. So again, might be a little bit of crossover with anorexia type symptoms. So when people have these types of physical signs and symptoms, we really need to start looking at the whole picture and trying to make an assessment of what their eating patterns are like, and we need to find out about their purging. So I'm not sure if you know what Russell's sign is, but that is actually like a callus on usually it's like the third knuckle, and that's usually because most of the time that's the longest finger, and so that is the finger that is used to put down their throat to make themselves gag and induce vomiting. So they can do it so often that they actually get a callus on their knuckle. So all those different physical signs are really important to kind of look for. Emotional and relationship signs. Many times we have impulsive and compulsive behaviors. So again, we see a little bit of crossover now between these eating disorders again and addiction and obsessive compulsive disorders. There is a chart of the DSM-5 criteria for bulimia right on the top of page 342, and they talk about the frequency that somebody exhibits these behaviors. And so it has to be, in order to receive a diagnosis, at least once a week for at least a 3-month time period. And the reason there's time limits on that is sometimes there are copycat eating disorders, the same way that there are copycat people that self-harm. So somebody in school is rubbing their skin with a pencil eraser and abrading their skin. Somebody else copies that because the person says it makes them feel better, but they may really never fully develop that disorder. Same thing with eating disorders. So somebody might hear a friend talk about purging or binging and then purging and then losing some weight, and then somebody might think, well, I'm going to try that too, and they do, and they try it. They try a little bit of binging and purging, but they don't keep it up on a continuous basis. So, and they even further define mild, moderate, severe, and extreme being an average of 14 or more episodes of inappropriate compensatory behavior per week. So that would be probably vomiting or using diuretics, laxatives twice a day or more. Wow, that would be pretty incredible. And think about the fluid and electrolyte imbalance that that person would be going through. So, anyways, we do really have to take a look at the behavior and the frequency and that compulsive aspect of it. Times we see chaotic, non-nurturing family relationships, family and or social instability, and difficulty with interpersonal relationships, not only within the family, but also that extends to other people. So perhaps the child or even young adult is seeing that the family, the parents have difficulties with interpersonal relationships with other people, and perhaps they don't have any support systems outside of the immediate family. Top of page 343, there's a nice little green table that's called Thoughts and Behaviors Associated with Bulimia Nervosa, and they do talk about having difficult interpersonal relationships, self-concept, and impulsive behaviors. So self-concept is also something we really need to think carefully about, because they don't have the same type of distortion that people with anorexia do. So they're not going to look into a mirror and actually be emaciated and see themselves as somebody who's fat, but they definitely have body image issues. They're very unhappy with their body image. So that's a little bit of a similarity, but certainly a difference too, because it's not quite the same as when somebody has anorexia. So another little cartoon that I found, emotional eating doesn't heal emotional issues. And certainly that is really very, very true. And that's something that these patients really need to find out in therapy. And the rest of the saying is, when you overeat, it's because you're avoiding a needed conversation with yourself. Swap pigging out for listening up. So it looks like it's kind of a do-it-yourself. I didn't really look into the program, but it kind of looks like maybe a self-help type of online group. And while that could be, very true, it's something that is very difficult for that person to just do themselves. They can't just stop the cycle of binging and purging. They really do need some expert help in order to do that. I don't know anybody personally, I guess, that has had success with just trying a self-help program. But certainly I think the part about emotional eating doesn't heal emotional issues really truly is right on the money. So some behavioral assessments then in bulimia, we really need to look at their binge eating behaviors. What do they binge on? How often? When? Usually those the binges occur in secret. Usually nobody is binging in front of another person. And there was a student I had a long time ago that said she probably suspected that one of her college roommates in a previous college situation probably had bulimia. This girl would come back to their house that they rented. I think there were 4 or 5 girls in a house, and they'd have a big bag of food, like from McDonald's, and they would all think, oh, great, she's brought enough food for all of us. And then that person would go up to their room by themselves and close the door, and they just didn't see that person the rest of the night. So the guess would be that they figured out after a while that more than likely this person was eating all that food themselves and then purging. So we do have to take a look at what their eating behavior actually looks like. And then again, the self-induced vomiting, laxative or diuretic abuse after binging, or even more than one. It usually isn't mutually exclusive. Sometimes people can use more than one method to try to get rid of the purging. So kind of think of that defense mechanism of undoing. So I wonder if anybody thought of that, because truly purging is like undoing that large binge that you have. I mean, when people binge, they really don't feel good about themselves. They really feel physically, I mean, maybe emotionally at first they feel good, but they truly do usually end up feeling rather negative about themselves, and then physically, of course, feeling awful because they are so overstuffed, and that's at the point then that they do the purging behavior. So think about undoing, trying to undo all that negative that they just did. They definitely are going to have depressive signs and symptoms, and again, problems with relationships and self-concept. So, but again, a little bit different from the self-concept and the body image distortion that we see in anorexia. People with this disorder can have impulsive behaviors and even possible impulsive stealing. So again, thinking about the different illnesses we've previously talked about, and obsessive compulsiveness, and just how the neurotransmitters are all playing a role in that. So it also plays a role in illnesses like bulimia, anxiety certainly, and compulsivity. So impulsive and compulsive behaviors, possible chemical dependency. So again, there certainly is a compulsive nature to chemical dependency, and also impulsive. They may also have a history of anorexia nervosa, so the eating disorders are, they can occur in the same person at the same time. They do have distinct signs and symptoms, but they can overlap, and they can, I have heard people being diagnosed with anorexia and bulimia at the same time. I believe they used to call it bulimorexia. Not sure if that term is still used at all, but definitely a history of anorexia is something that we will often see in people that have bulimia. So physical assessments in bulimia, usually again that normal to slightly below normal weight, dental caries, tooth erosion, parotid swelling, calluses, gastric dilation and rupture, of course, would be a very serious physical assessment, and that would certainly be from the amount of binging. Possible peripheral edema, muscle weakening, abnormal lab values, sodium and potassium, cardiac abnormalities, and cardiac failure is also a consequence. On the top of page 344, there's a small purple table, possible signs and symptoms of bulimia. And so they talk about these symptoms, and then in big, bold black letters, the electrolyte imbalances that are experienced can lead to death. So we have to take that very seriously. And then right below it, ipecac intoxication, which is very interesting. I guess it must still be on the market somewhere. I should look for that the next time I go to Walgreens just to see if I can find it. But anyways, and that is, again, what caused Karen Carpenter to pass away. So all things that are really quite important to look at. Diagnosis and outcomes. Some of the diagnoses that we can think about for this disorder would be decreased cardiac output, disturbed body image, ineffective coping, powerlessness, chronic low self-esteem, and social isolation. So, and of course, that social isolation comes from, again, that inability to eat with other people, they kind of do their binging and purging in secret. And so therefore, they're not spending a lot of time with people, and they do have alterations in basically in their relationships and communication with people anyways in general. So the outcomes, we're hoping for that the electrolytes will become imbalanced again, in balance, not imbalanced. They will become in balance so that they're good. Adequate cardiac output, satisfaction with body image, effective coping, verbalizing confidence, makes informed life decisions, expresses independent decision-making, willingness to call others for assistance, and develops that sense of belonging. It's really important when we're thinking about working with somebody with bulimia, as far as teaching, to help them to recognize other aspects of their self that are positive. So for them to be able to make a positive self-statement about something that doesn't include eating, that has nothing to do with eating behavior or food, is actually quite positive. So they also sometimes use journaling to try to help them to connect their feelings that they have with their binging. So if you can try to help them to identify some triggers, and journaling can be a very effective way of helping people to do that. So they write in their journal, I was looking on Facebook and noticing everybody having a great time together, and I felt really lonely, and so I wanted to binge. That would be a great way for that person to maybe make a connection. What is triggering them emotionally to do that binging, purging behavior? So food is kind of the thing that has been giving them comfort. So for them to be able to find other ways to cope and other outlets would be very positive, and for them to be able to, again, recognize some strengths that are not associated with food or cooking or anything like that would be a great outcome. So some interventions then always, teamwork and safety is very first and foremost, and these patients also might exhibit some other types of self-harm behaviors, including cutting and things like that, cutting, burning, whatever they can get a hold of, and also they may also possibly have some suicidal ideation that we need to assess for and make sure that they stay safe. Pharmacological interventions, person with bulimia who would be treated on an inpatient eating disorders unit would also have that same amount of structure that somebody with anorexia does, and the hope is to interrupt that binge purge cycle and the rest of their disordered eating behavior. So observing during and after meals to prevent purging, normalizing their eating patterns. Again, they really have to be almost taught from scratch as to what consists a healthy meal and healthy portion sizes. Appropriate exercise integrated into the unit, and the multidisciplinary treatment team uses a comprehensive treatment approach. They have to address the emotional and behavioral problems that occur when the patient no longer is able to binge and purge. So they may have some behavioral disruptions on the unit that the staff will have to help them with. And again, they can have excessive amounts of anxiety when they're prevented from using their usual method of coping, which of course would be the binge purge cycle. I think I was starting to talk about pharmacological interventions and then kind of skipped over that. Well, anyways, basically, therapy and medication can be very helpful with bulimia, especially Prozac. So there are other medications, possibly Topamax might also be helpful in suppressing the urge to binge, and also some tricyclic antidepressants have helped reduce the binge eating and vomiting. So we do, again, there isn't a specific medication that is marketed specifically for bulimia, but some of those antidepressant type medications and mood stabilizers can certainly be very helpful. So counseling, establishing that therapeutic alliance with the nurse is very important. Again, goes right back to the very first learning plan with developing that therapeutic nurse-patient relationship, and also, of course, with other members of the multidisciplinary healthcare team. And you're just really hoping that the patient will be able to accept feedback regarding the patient's distorted beliefs. So health teaching and health promotion, again, we have to really make sure that they understand the hazards of using different types of methods to purge, and they really need some information about what are the signs and symptoms of hypokalemia, because they should be aware of those. If they are continuing to binge and purge, then they need to know those signs and symptoms so that they can receive medical help. Advanced practice nurse may be engaged in psychotherapy, of course, usually cognitive behavioral therapy, which is the most effective type of therapy for this disorder. Overall goal of that therapy really would be to help that person to develop more of a positive attitude towards themselves, and certainly their body image, but of course also that they are more than just their body, that they are a whole, complete person, and really, again, to focus on other aspects, other strengths that they have as a person. And of course, we're always evaluating not just the advanced practice nurse. It kind of looks funny the way it's put on this slide, but of course, we're always evaluating our goals and making sure that the patient is meeting the goals. And we're trying to, as nurses, we're trying to assist them to really look at their goals and to try to meet them in a very positive way. Lastly, we're going to be talking about binge eating disorder. So that is engaging in repeated episodes of binge eating without those compensatory behaviors. They do experience significant distress after they have a binge. Guilt, depression, disgust, or embarrassment. And again, usually people are binging in secret. They're not binging in front of other people, but they really, truly do feel very badly about themselves afterwards, and they don't, the binging initially is something that is helping them to cope. It's certainly a coping mechanism, but the after effect is that they usually end up feeling very much worse about themselves, and then they don't engage in any of those compensatory behaviors. They're not taking laxatives, diuretics, exercising, or vomiting, any of those things. So the video that the YouTube video that I put under this learning plan 9 on binge eating disorder, it really is a great video to watch. It's very short, but it really shows the emotional aspect of this disorder, and it's very easy to see with this person's background why he developed binge eating disorder. And certainly he describes his struggle and his hopes and aspirations really quite well. So it's very worth the watch. So epidemiology, comorbidity, it's actually the most common eating disorder. And it's about 3.6% in females, 2.1% in males as a lifetime incidence. Common psychiatric comorbidities: bipolar disorder, major depression, anxiety, substance use. And then the physical comorbidities usually relate to obesity and all of the sequelae that can develop as a result of obesity. And once again, I know this is not a med-surg course. However, we do have to think about the physical aspects. So I know that you know a lot of the side effects of obesity already: high blood pressure, cardiac issues in general, possibly even respiratory issues, high cholesterol, high risk for stroke, diabetes, things like that. So those are all the types of comorbidities that we would really be especially worried about. So as far as assessment, we are looking at a general assessment. So we really always are looking at the patient's perception of the problem, what they think is going on. A complete nursing assessment, of course, would be important. Vital signs, review of systems, general appearance, psychosocial history, nutritional pattern, what do they binge on, how often do they binge, and their history of weight cycling. So sometimes people have histories of kind of chronic going on binges and then also trying to lose some weight. So they may have kind of like a yo-yo dieting thing going on too. Triggers, absolutely triggers. And again, what types of foods are they most likely to be binging on? So lots of things to be thinking about when we're thinking about binge eating disorder. So the patient really is having episodes where they feel that their eating is just completely out of control. So again, I'm referring you back to that video as a really great example of a person who had some very, very outstanding triggers to his binge eating. The self-assessment, again, relates to our feeling that perhaps obesity is a personality flaw, it's a failure to have self-control, and that they don't have good eating and exercise habits. So that, that is certainly part of our culture. Obesity is still the subject of jokes and discrimination, and nurses really have to be very aware of possible negative reactions to these patients, especially if they are very obese. So some nursing diagnoses that would apply: imbalanced nutrition, more than body requirements, disturbed body image, ineffective coping, anxiety, chronic low self-esteem, powerlessness, and again, that social isolation. And this social isolation comes from not being able, many times not even being able to participate in other activities. Again, that video really very clearly shows this this man who feels that he really would like to be able to ride a bike. He'd like to be able to go on go to a fair and go on a Ferris wheel or some kind of a ride that he doesn't feel he can do now. So he tends to isolate himself because of his size. And so that would be a very, very common nursing diagnosis. And just from the embarrassment and the fear of being judged by other people. So all good diagnoses that really do apply to this disorder. So we always need to identify outcomes and of course involve the patient in setting up their goals. So, and the nurse really needs to help the patients manage this dysregulation of their entire gastrointestinal tract. So again, what do they binge on and how often, what amount, the time of the day. Sometimes people binge at night when nobody else is up. They get up in the middle of the night and they go on a binge. Certainly could be any time of the day or night, but really we always want to find out what is happening with that individual person. So this is just a little bit of a cartoon about comfort foods. In the video, the man who has the binge eating disorder talks about sandwiches being a comfort food for him. So this cartoon is almost saying like it's kind of would be nice if comfort foods would say things to us that are positive, like let a smile be your umbrella, keep your sunny side up, don't worry, be happy. That would be great if comfort foods would do that for us, but that isn't quite exactly how it works. But certainly people are seeking comfort in their binge episodes. I also found this little cartoon that is talking about, it's from that same, I think, self-help group. Someone should open an ice cream shop with flavors like "Don't be sad" and "You deserve better." So again, just kind of cute little way to think about how important food is to us culturally. Comfort foods. We certainly all have foods that represent different things in our lives, whether it be comfort or nurturing, or perhaps there are some foods that we absolutely don't like because we have a negative connotation to that food. So it is interesting the way that we tie our emotions sometimes to different types of foods. So yes, it would be nice if there was an ice cream shop with flavors like "Don't be sad" and "You deserve better." Just let's, give people some positive affirmations that they can think about. Okay, anyways, the assessment is certainly looking at that dysfunctional eating pattern. Their weight is significantly over their ideal for their height and frame. They eat as a coping mechanism and usually in the absence of other effective coping methods. They truly don't have any other ways that they are using to cope. They eat even when they're full. They feel when they're on a binge that they have an absolute loss of control of their eating. And of course, then they have feelings of shame and guilt, and they do hide their eating behavior from other people. So interventions, acute care. People aren't usually on a mental health unit for binge eating disorder. They may not even be on a medical unit for binge eating disorder unless they are going in for some specific type of bariatric intervention like surgery. Kind of the third bullet point down talks about some people may have surgical intervention. Certainly not everybody chooses to go for that route, but most of the time people are being maintained as an outpatient. Sorry, I got a little bit interrupted there. Anyways, so we're talking about binge eating interventions. So certainly that developing that nurse-patient relationship can be very helpful as far as the psychosocial interventions. Working on alternative ways to cope would be very pertinent. Pharmacological interventions, on page 349, there's a whole table of FDA-approved drugs for weight reduction. However, I'm not going to be testing you truly on any of those. But on page 348, there's a little paragraph on pharmacological intervention. So just to note that there are some medications like the SSRIs that can be used to help, and also Vyvanse, which is a medication used to treat ADHD, is actually also approved to treat binge eating disorder in adults. So some of the meds we use for other purposes can also be very helpful. So possibly some of those drugs might be used, but usually, again, combination of medication and therapy is usually the most helpful. I think I talked about bariatric surgery as a possible surgical intervention for some patients. Health teaching and health promotion always, because they truly need to learn how to cope differently and not to use food to regulate their mood and as a coping mechanism. Very, very important. And again, they also need help with healthy portion sizes and what constitutes a meal, because they truly have lost sight of those things in the same way that somebody with anorexia and bulimia have. Teamwork and safety, always assessing their full psychosocial status and then intervening in ways to keep them safe. If they happen to become suicidal, we certainly need to keep an eye on that. There are patients that become very hopeless that things will ever change, and that may prompt them to feel suicidal. Safety would also focus on physical safety, as in their blood pressure, their vital signs in general, and just looking for other negative effects of obesity. So, and then the teamwork, actually, I didn't say this before, but truly a dietitian would be a very valuable part of the interdisciplinary treatment team for all eating disorders, certainly for binge eating, but also for people that have bulimia and anorexia. So we can't factor out that would be a very important aspect of the treatment team, and that working together. Advanced practice interventions, psychotherapy, very, very helpful for the person to, again, be able to identify triggers and to try to work on ways to avoid those triggers or cope with them in a little bit of a different way. And then we're always evaluating and looking for the person that they have a better eating pattern, that it's more stabilized, that their mood is improving, and that they are no longer suicidal if they have felt suicidal, and that they aren't having episodes of binge eating. So community-based treatment, usually for acute care, people are admitted in a crisis. So again, we have to establish trust, assess for priorities. In outpatient treatment, it really is very helpful to the patient and family for us to become involved with them and try to do some teaching, education, and support. That is so, so helpful to the family. Communication issues in the family have to be addressed, and it may involve a contract to maintain a medically stable weight. And your book kind of describes the fact that if the patient comes to their outpatient appointment and they are say if they have anorexia and or bulimia, and they are not supposed to be losing weight, and they come and they have lost weight instead of gaining weight, then perhaps they may have to make a referral to a different program or another care provider because they have broken their treatment contract. So treatment contracts can be a very important part of that whole aspect of community-based treatment. Community issues, so the last PowerPoint slide for this learning plan, we really do have to be aware of internet influences, and that there might be, oops, I just hit something wrong here. I'm afraid to hit this because I think, okay, I'm really not very tech savvy. Okay, anyways, where was I? So we have to think about internet influences that might be detrimental to the person who has an eating disorder. There is a lot of information out there. There are a lot of support groups. There are a lot of websites for the different eating disorders, but we have to be really careful before we refer somebody or recommend a site to somebody check it out yourself, because so many of the internet sites that are especially for people that have anorexia, they're actually called pro-ana sites. Ana short for anorexia, and they actually teach people how to be anorexic, how to hide it better from your family, how to lose more weight, how to be more deceptive so that other people don't figure out that you're losing weight. So not helpful at all. So we have to be really, really careful about that. So the internet's a great thing, but sometimes it can be very detrimental also. So that's the end of Learning Plan 9. I will see you for Learning Plan 10.